Welcome everyone. I'm excited to have you here today for our training session. Today, we'll be exploring spinal fusion procedures and how to accurately code them using ICD-10 PCS. Our presentation is titled Definition, Approaches, Columns, and Coding Examples, and it's part of the Visu online training series. Over the course of this session, we'll cover the key concepts behind spinal fusion, different approaches used, how to interpret columns in the coding process, and review some practical coding examples. I'm glad you're here, and I look forward to guiding you through this important topic. Joining two or more vertebrae permanently is what we call spinal fusion. Essentially, it means the bones are fused together so they no longer move independently. This procedure is typically used to address issues like spinal instability, fractures, scoliosis, or spinal stenosis. By doing this, we can help reduce pain and provide much-needed stability to the spine. So, in a nutshell, spinal fusion is about stabilizing the spine when other treatments might not be enough, helping patients regain comfort and function. So let's take a look at some of the common diseases and the reasons why spinal fusion might be necessary. First, we have DDD, or degenerative disc disease, which often leads to disc collapse and causes significant pain. Then there's spinal stenosis, a condition where the spinal canal narrows, leading to nerve compression and symptoms like numbness or weakness. Next, spondylolisthesis involves one vertebra slipping over another, which can destabilize the spine and cause discomfort. Scoliosis refers to abnormal curvature of the spine, which can affect posture and sometimes lead to pain or functional issues. Fractures, whether from trauma or structural weakness, can cause bones to break or become unstable, requiring stabilization. Tumors in the vertebral bodies can lead to destruction of bone tissue, compromising the spine's integrity. And finally, structural instability from any of these issues, be it a fracture, tumor, or deformity, can be a key reason for performing a fusion. Essentially, the goal of fusion is to stabilize the spine, relieve pain, and restore function when these conditions threaten the spine's stability and health. Today, I want to focus on the root operation called fusion, which is represented by the letter G. Fusion involves joining two articular body parts. So essentially, we're connecting bones at a joint. The main goal here is to render that joint immobile, meaning we want it to stay fixed in place. This is often done to stabilize the joint or to promote bone growth in certain medical conditions. When we talk about ICD-10 PCS, fusion is defined as a procedure that joins these parts to achieve stability and encourage new bone formation. So, in the context of our broader discussion, understanding this operation helps us see how surgical techniques are aimed at controlling movement for better patient outcomes. Now, let's take a closer look at Slide 5, which focuses on the section of medical and surgical procedures, specifically related to the spine regions. When we talk about fusion as a root operation, we're referring to a procedure that permanently joins two or more vertebrae to stabilize the spine. This is a common approach in treating various spinal conditions. It's important to understand that the characters involved in coding these procedures include the body part, which in this case is the spine or specific vertebrae, the approach used to reach the site, whether it's anterior, posterior, or lateral, the device involved, such as screws or cages, and any qualifiers that provide additional details about the procedure. Now, the PCS code structure is designed to be systematic, capturing these key components, body part, approach, device, and qualifiers in a structured way. This helps ensure clarity and consistency when coding these complex procedures. Overall, understanding how these elements come together in the PCS code structure allows us to accurately document spinal fusion surgeries, which is essential for proper coding, billing, and analysis. So, when you see a fusion procedure in the spine, remember that all these characters work together to create a precise and comprehensive code. Now, let's take a closer look at some of the key components involved in spinal fusion procedures. First, we have the interbody fusion device, commonly known as a cage. This device is inserted between the vertebrae to provide stability and a scaffold for bone growth. It plays a crucial role in supporting the spine as the fusion process takes place. Next, we have the autologous bone graft. This is bone harvested from the patient's own body, typically from the pelvis. The advantage here is that it's highly compatible and promotes faster, more reliable fusion because it contains the patient's own cells and growth factors. On the other hand, there are non-autologous grafts, which are donor or synthetic materials used when autologous bone isn't available or suitable. These can include allografts or synthetic substitutes, and they help fill the space and stimulate fusion, although they may have different integration profiles compared to autologous grafts. Moving on, internal fixation devices are also critical. They include screws, rods, and plates that secure the vertebrae in proper alignment during the healing process. These devices ensure stability and maintain the correct spinal curvature as the fusion occurs. All these elements come together as fusion devices, working synergistically to promote solid spinal fusion. Each component, from the cage to the grafts and fixation devices, plays an integral role in achieving a successful outcome. Connecting this to the overall theme, effective spinal fusion relies on the careful selection and application of these devices and materials to restore stability and function to the spine. Let's take a closer look at the spinal columns. On the anterior column, we have the vertebral body and disc, which are critical for supporting weight and allowing movement. Moving to the middle column, that includes the posterior part of the vertebral body, providing additional stability. And then, on the posterior side, we see the lamina and facets, which form the back part of the spinal arch and are essential for protecting the spinal cord and enabling flexible motion. Now, there's also a qualifier that indicates which column is fused, which is important when understanding spinal stability or surgical procedures. Overall, these columns work together to support, protect, and enable the complex movements of our spine. Recognizing these divisions helps us better understand spinal anatomy and how different conditions or treatments might affect specific parts of the spine. Now, let's take a look at the different approaches to this procedure. First, we have the open approach, which involves making a large incision to directly access the area. This method provides maximum visibility and control, but it's more invasive and typically used for complex cases. Next, there's the percutaneous approach, where we use needle access. This technique involves inserting a needle through the skin to reach the target area, often guided by imaging. It's less invasive than open surgery and can be advantageous for smaller or less complicated situations. Then we have the endoscopic approach, which is scope-assisted. This method uses a flexible or rigid scope to visualize and operate within the body through small incisions or natural openings. It offers excellent visualization and minimizes tissue trauma. Understanding these different approaches helps us tailor the procedure to each patient's specific needs, balancing invasiveness, safety, and effectiveness, key themes that run throughout this presentation. When considering surgical approaches, it's important to understand the differences between anterior and posterior methods. On the anterior side, we typically make an abdominal incision, often referred to as an ALIF, which stands for anterior lumbar interbody fusion. This approach allows us to access the spine from the front, giving us a direct path to the disc space and vertebral bodies. On the other hand, the posterior approach involves making an incision along the back. This is where we place pedicle screws, which provide stabilization by anchoring into the pedicles of the vertebrae. Both approaches have their specific indications and advantages, and understanding these key differences helps us tailor the surgical plan to each patient's needs. The anterior approach is often chosen for disc-related issues or anterior column reconstruction, while the posterior approach provides excellent access for stabilization and decompression. Recognizing these operative details is crucial as we consider the overall strategy for spine surgery. Now, let's take a look at some of the common fusion techniques used in lumbar spine surgery. First up is ALIF, which stands for anterior lumbar interbody fusion. In this approach, we access the spine from the front, allowing us to remove the disc and place the graft or implant directly between the vertebral bodies. This method offers the advantage of good access to the disc space and minimal disruption of the back muscles. Next, we have PLIF, or posterior lumbar interbody fusion. For this technique, the approach is from the back. We make an incision over the spine, remove part of the lamina, and access the disc space to perform the fusion. This approach gives us direct visualization of the nerves and is often preferred in certain cases. Then there's TLIF, transforaminal fusion. This approach is also from the back, but it's more lateral, going through the foramen, the opening where the nerve roots exit. TLIF allows us to access the disc space with less retraction of the nerve roots and less disruption to the spinal canal, which can be beneficial in reducing some risks. Finally, XLIF, or lateral approach fusion, involves approaching the spine from the side. This lateral approach minimizes the need to move or manipulate the nerves and muscles from the back. It provides a direct path to the disc space, especially useful in certain cases where posterior approaches are more challenging. All these techniques, ALIF, PLIF, TLIF, and XLIF, are tailored to the patient's specific condition and anatomy. Understanding the differences helps us choose the most effective and least invasive method to achieve spinal stability and pain relief. They all connect back to our overall goal of restoring function and reducing discomfort through precise surgical intervention. Let's start by understanding how we code each joint that has been fused. It's important to accurately identify which joints are involved in the fusion procedure. Next, we need to determine the correct approach for coding, whether it's a primary or secondary procedure, since this impacts the coding strategy. Remember, the device used for the fusion must remain in the body for the code to be applicable, so we need to verify that. Also, pay attention to the column that determines the qualifier. This helps specify the exact nature of the procedure. Finally, always refer to the PCS coding guidelines, which provide detailed instructions and clarifications to ensure our coding is precise and compliant. These points are crucial for accurate documentation and reimbursement, and they tie back into the overall goal of coding with accuracy and consistency. Today, I want to highlight a specific case involving a patient with a diagnosis of L4-L5 degenerative disc disease, or DDD. In this instance, the treatment performed was an anterior lumbar interbody fusion, commonly known as ALIF. This procedure is indicated for cases like this, where the disc degeneration causes significant symptoms or instability. The diagnosis code associated with this condition is M5136, which helps us categorize and track the patient's diagnosis accurately. Regarding the procedure, we use the PCS code 0SG00AJ, which stands for a fusion of the lumbar anterior column through an open approach. Essentially, this means we access the spine from the front, removed the degenerated disc, and fused the vertebrae to stabilize the segment. This slide reinforces how we classify and document these interventions, connecting the diagnosis with the specific surgical approach used. It's a good example of how precise coding and understanding of the procedure are critical for effective treatment planning and documentation. In this slide, we're looking at a typical coding scenario involving a procedure called a laminectomy combined with a posterior fusion at the L5-S1 level. This is a common surgical approach to treat lumbar spinal stenosis, which is what we'll focus on next. The diagnosis here is M48061, which specifically indicates lumbar spinal stenosis. This condition involves the narrowing of the spinal canal, which can compress the nerves and lead to pain, numbness, or weakness. In terms of procedural coding, we use the codes 0SG3071 for the posterior fusion and 0SN00ZZ for the decompression or release part of the surgery. These codes help accurately document the surgical interventions performed. The key definition to remember is that spinal stenosis is essentially a narrowing of the spinal canal that causes nerve compression. This is crucial because it guides both the diagnosis and the treatment approach. Speaking of treatment, the main goal is decompression, relieving the pressure on the nerves. Sometimes, a fusion is also necessary if there's instability in the spine after decompression. Overall, understanding this scenario helps us appreciate how diagnosis, coding, and treatment are interconnected in managing spinal stenosis effectively. Let's take a closer look at spondylolisthesis. This condition involves the forward slipping of one vertebra over the one below it. It's a common issue that can cause significant pain and nerve problems. In terms of diagnosis, it's classified under ICD-10-CM as M4316, specifically affecting the lumbar region. Now, why do we consider fusion in these cases? The main goal is to prevent further slippage and protect the nerves from ongoing damage. If the vertebra continues to slide forward, it can lead to worsening symptoms and complications. The procedure we're discussing here is a TLIF, which stands for transforaminal lumbar interbody fusion, specifically at the L4-L5 level, using a cage. This helps stabilize the spine and promote fusion between the vertebrae. In terms of diagnosis coding, we again refer to M4316, and for the procedure, the CPT code is 0SG30AJ, which describes a fusion of the anterior column via posterior approach. Overall, this approach aims to provide stability and long-term relief, aligning with our broader goal of restoring function and preventing future issues. Let's talk about scoliosis. Scoliosis is an abnormal lateral curvature of the spine, meaning the spine curves sideways in an unusual way. In the ICD-10-CM coding system, the code for scoliosis that isn't specified further is M4019. The main purpose of performing spinal fusion in scoliosis cases is to correct the deformity and maintain proper spinal alignment. This helps prevent the curve from worsening and improves the patient's posture and function. In a typical coding scenario, if a patient has a posterior multi-level fusion from T10 to L2, we would use the diagnosis code M4019. For the procedure itself, multiple PCS codes are assigned for each joint that's fused, such as 0SG3071 or 0SG4071, depending on the specifics of the surgery. Overall, understanding both the diagnosis and the surgical approach is crucial for accurate coding and effective treatment planning. Let's talk about herniated discs. A herniated disc occurs when the disc material protrudes and compresses nearby nerves, which can cause significant pain and neurological symptoms. In the ICD-10-CM coding system, this condition is classified as M5127, which refers to disc displacement specifically in the lumbosacral region. Now, when do we consider fusion as part of the treatment? Typically, fusion is needed in cases of recurrent herniation or when there's segmental instability. Recurrent herniation means the disc herniates again after initial treatment, and segment instability indicates that the spinal segment is not stable, risking further damage if left untreated. Let's look at a common coding scenario. Suppose a patient undergoes a discectomy combined with fusion. The diagnosis, as I mentioned, would be M5127. For the procedures, we use for the excision of the disc and 0SG3071 for the fusion itself. Understanding these codes helps us accurately document the treatment and ensures proper billing. It also highlights the importance of tailoring surgical interventions to the patient's specific condition, whether it's just removing the herniated disc or also stabilizing the affected segment through fusion. This approach ultimately aims to restore stability and alleviate symptoms effectively. Let's take a closer look at spinal fractures. A spinal fracture is essentially a break in one of the vertebrae, which can lead to instability in the spine. This is a critical point because instability can affect the spine's ability to support the body and protect the spinal cord. In terms of coding, you might see examples like S32009A, which indicates a lumbar fracture during the initial encounter. It's important to note that the main reason for performing a fusion in these cases is to restore spinal stability, helping to prevent further injury or deformity. Now, when it comes to a specific coding scenario, imagine an open reduction plus fusion procedure. The procedure coding system, or PCS, includes codes like 0QS004Z for repositioning the fracture and 0SG00AJ for performing the fusion itself. These codes help accurately reflect the surgical intervention performed. Overall, understanding the purpose of fusion and how it fits into the broader context of spinal injury management is key. It's about stabilizing the spine to promote healing and preserve function. Let's take a closer look at spinal tumors, specifically those that involve the vertebral body. When we talk about a spinal tumor, we're referring to a growth that is destroying the vertebral body, which can compromise the stability of the spine. In medical coding, this type of tumor is classified under ICD-10-CM as C7951, indicating a secondary malignant neoplasm of the bone, meaning it's a metastasis from another primary site. Treatment options for these tumors often involve surgical intervention, with corpectomy being a common procedure. This involves removing the affected vertebral body to eliminate the tumor. To restore stability after removal, fusion stabilization is performed, which means fusing the adjacent vertebrae to support the spine. When coding for these procedures, we combine the corpectomy with the fusion. In the procedure coding system, or PCS, this is represented by specific codes: 0RT90ZZ, which indicates a resection of the vertebra, and 0SG00AJ, which is used for the fusion process. Understanding these codes and treatments is essential because it helps us accurately document and communicate the complexity of these cases. This aligns with our overall goal of precise coding and effective treatment planning for spinal tumor management. So let's talk about how fusion actually helps in curing disease. Fusion works through a few key steps. First, it involves removing the diseased disc or bone that's causing problems. This is important because removing the source of pain or instability is the first step toward healing. Next, it stabilizes the motion segment, which means it helps keep that part of the spine steady and prevents unnecessary movement that can cause pain or nerve damage. Then, a bone graft is used to promote healing. Think of it as a bridge that encourages the vertebrae to grow together. Over time, the vertebrae actually fuse, becoming one solid piece. This fusion provides long-term stability and helps restore proper function. The overall result of this process is really significant. Patients often experience a reduction in pain, which is a huge relief. It also protects the nerves by stabilizing the spine, preventing further nerve compression. And of course, it restores structural stability, which is crucial for maintaining mobility and quality of life. So, in essence, spinal fusion is a powerful tool that directly addresses the root causes of many spinal problems, helping patients recover and regain their normal activities. Today, we're focusing on the L4-L5 anterior interbody fusion, a common procedure used to address issues at this spinal level. This approach is performed through an open anterior route, which means we access the spine from the front. One of the key points here is that this approach allows direct access to the anterior column, the front part of the spine structure, which is crucial for stability and alignment. When we talk about the coding scenario, an example is PCS, 0SG00AJ, which helps us identify the specific procedure in our documentation. The clinical scenario we're referencing is an ALIF, or anterior lumbar interbody fusion, a popular technique for treating degenerative disc disease or instability at L4-L5. Understanding this approach and coding is essential because it not only streamlines documentation, but also ensures proper reimbursement and clarity in surgical reports. So, in summary, this slide highlights the importance of the anterior approach at L4-L5, focusing on the anterior column, and how we categorize and code this procedure accurately, especially in the context of ALIF. Now, let's focus on posterolateral fusion at the L5-S1 level. This procedure involves stabilizing the spine by fusing the vertebrae from a posterolateral approach. The key point here is that the approach is from the back, which allows us to access the posterior column of the spine. The posterior column includes the bony structures and soft tissues that support the spine's stability. In this context, The example PCS code is 0SG3071, which specifically relates to posterior fusion procedures. When coding this scenario, we're looking at a posterior fusion, which is critical for addressing certain spine pathologies like degenerative disc disease or spondylolisthesis at L5S1. Understanding the approach, posterior in this case, is essential because it influences both the surgical technique and the coding. It's a common approach because it offers direct access to the posterior elements, making it effective for fusion at this level. So, to sum up, posterolateral fusion at L5S1 via posterior approach involves stabilizing the spine from the back, targeting the posterior column, and is often coded under specific PCS codes like 0SG3071. Recognizing these details helps ensure accurate documentation and billing, which is a key part of our overall presentation on spine procedures. Let's take a look at some of the key types of spinal fusion procedures. First, we have the anterior plus posterior fusion. This involves fusing two columns of the spine, meaning both the front and back. It's a comprehensive approach that provides additional stability. Because you're fusing multiple areas, it typically requires multiple fusion codes to accurately capture all the work involved. Next, there's the 360-degree fusion. This term really emphasizes that the fusion encircles the entire spinal segment, both the anterior and posterior aspects. It's often used when a complete stabilization is necessary, especially in more complex cases. Understanding these options is crucial because they help us determine the extent of the procedure and ensure proper coding. Ultimately, choosing between these types depends on the patient's specific needs and the goal of achieving maximum spinal stability. Now, let's talk about some of the common procedures involved in spinal surgeries. First, we have excision, which refers to the partial removal of tissue or a structure. This might be used when only a part of a problematic area needs to be addressed. Next is resection, which involves the complete removal of a specific part. This is often necessary when a whole segment is diseased or damaged beyond repair. Then there's release, which is about decompression, relieving pressure on nerves or the spinal cord to reduce pain or neurological symptoms. It's important to note that these procedures may sometimes require separate coding, depending on the complexity and the specific approach taken. And of course, there are additional procedures that might be performed alongside these main interventions to achieve the best outcome for the patient. Understanding these distinctions helps us better communicate what's involved in each surgical plan and ensures accurate coding and documentation. All right, let's look at slide 24, which covers discectomy before fusion. The key point here is that we're dealing with a root operation called excision. This means we're removing a part of the body, specifically the disc in this case. When coding this procedure, the example PCS code is. What's important to remember is that excision involves cutting out tissue, often to relieve pressure or to prepare for fusion. In this context, performing a discectomy before fusing the vertebrae ensures stability and relieves nerve compression. Understanding this sequence helps us accurately capture the procedure's intent and extent. So, this slide emphasizes the importance of recognizing excision as a root operation and how it fits into the overall treatment approach. So, in this slide, we're looking at a corpectomy procedure, which involves removing an entire vertebra. This is a significant surgical step, especially when dealing with complex spinal conditions. By removing the entire vertebra, we create space to address issues like tumors, trauma, or infections that affect the vertebral body itself. The slide also provides an example of a PCS code, 0RT90ZZ. This code helps us standardize and communicate the specific procedure performed. In this case, it indicates a resection, meaning the removal of part or all of a structure, in this case, the entire vertebra. This example highlights the importance of precise resection techniques, as they are crucial for effective treatment and successful outcomes. Remember, the goal here is to eliminate pathology while preserving as much of the surrounding structures as possible. Overall, this step is a key component in complex spinal surgeries, especially when stability and decompression are necessary. It's a powerful tool in our surgical arsenal for managing severe spinal conditions. Now, let's talk about nerve root decompression, which is all about freeing the nerve from any constraints that might be causing pain or impingement. The key here is to carefully release those restrictions so the nerve can function properly again. An example of this in coding terms is the PCS code 0SN00ZZ, which helps us document the specific procedure. For a release example, imagine gently removing tissue or bone that's pressing on the nerve. This is a delicate but crucial step in restoring nerve function. Overall, this process is vital in spinal surgeries to ensure the patient regains nerve health and reduces symptoms. Let's take a moment to review the exposure section. It's important to ensure that we've adequately visualized the area we're working on. Next, look for signs of decompression, making sure that any previous or ongoing decompression procedures are properly identified and managed. Then, check the disc preparation. This includes inspecting the disc for any abnormalities or issues that could affect our surgical approach. It's also crucial to identify the therapeutic intent behind each step. Understanding what we're aiming to achieve helps guide our decisions throughout the procedure. Finally, be attentive to any additional procedures that might be necessary. These are steps we'll need to incorporate based on what we find during the operation. Overall, this review helps us stay focused and ensures that every part of the process aligns with our surgical goals, ultimately contributing to a successful outcome. Let's start by discussing how to identify the vertebral level. It's crucial to accurately determine this to ensure we're targeting the correct segment. This involves using anatomical landmarks and imaging guidance to confirm the exact level. Next, we'll review the approach used for the procedure. Whether it's anterior, posterior, or lateral, understanding the approach helps us plan and execute the interventions safely and effectively. Moving on, it's important to specify which column was fused during the procedure, whether it's the anterior, middle, or posterior column, as this affects stability and future management. Then, we'll look at the device used and any additional procedures that were performed. Knowing the type of hardware and supplementary techniques provides a complete picture of the surgical strategy. Lastly, proper documentation is vital. Accurate, detailed notes not only support patient care, but also ensure clarity for future reference and legal purposes. Covering these points thoroughly helps us maintain high standards and consistency in our practice. Now, let's talk about some of the common coding errors that can really impact the effectiveness of our data processing. One major mistake is missing decompression coding, which can lead to incomplete or corrupted data. Then, there's the wrong column qualifier. Using the incorrect qualifier can cause data to be misinterpreted or misplaced. Another frequent error is selecting an incorrect approach. Choosing the wrong method can result in inefficient processing or errors down the line. Also, not coding for multiple levels is a common pitfall. Failing to handle hierarchical or multi-level data properly can lead to gaps or inaccuracies. Overall, being aware of these common errors helps us to design better, more reliable coding solutions that support our broader data management goals. All right, let's walk through the key steps in our coding workflow. First, we need to identify the level. This means understanding what part of the data or process we're working with, whether it's a broad category or a more specific detail. Next, we determine our approach, how we're going to handle the coding based on the context and the goals of our project. Then, we identify the column. This is about pinpointing the exact data field or area we're focusing on. Once we've done that, we assign the device and qualifier, essentially, deciding which device or tool we're using and any qualifiers that refine our coding. All of these steps come together in a structured coding workflow, which ensures that our process is consistent, accurate, and aligned with the overall project objectives. These steps are fundamental because they help us systematically analyze and categorize data, making sure we're thorough and precise every step of the way. All right, let's talk about the different surgical approaches for spinal fusion. When we refer to ALIF, we're talking about the anterior approach, which means accessing the spine from the front. This approach is often chosen because it allows for direct access to the disc space and can be beneficial for certain cases. Then we have PLIF and TLIF, which are posterior approaches. These involve going through the back of the spine, providing a different angle to access the disc and vertebrae. PLIF stands for posterior lumbar interbody fusion, and TLIF is transforaminal lumbar interbody fusion. Both are commonly used but have different technical nuances. Next is XLIF, or lateral approach, which approaches the spine from the side. This method can minimize muscle disruption and potentially lead to quicker recovery. It's important to remember that the choice of approach often depends on the location of the fusion. For example, the column you choose may vary based on where you're targeting in the spine to optimize outcomes. Finally, understanding the differences between ALIF, PLIF, TLIF, and XLIF is crucial because each has its own indications, benefits, and limitations. Connecting these options to the overall surgical strategy helps us tailor the best approach for each patient's specific needs. All right, let's break down the key points here. So, when we talk about the interbody, we're referring to the anterior column of the spine. This is the front part that bears a lot of the load and provides stability. On the other hand, the posterolateral refers to the posterior column, which is more towards the back and side of the spine. It plays a crucial role in supporting the spine's structure and enabling movements. Now, when you see the term cage in this context, it usually indicates an anterior column approach. That's because cages are typically placed in the interbody space to restore disc height and promote fusion in the front part of the spine. Moving on to the difference between interbody and posterolateral fusion. This is important. Interbody fusion involves placing a graft or cage directly into the disc space, targeting the anterior column for stability and support. Posterolateral fusion, however, focuses on the area around the transverse processes, often using bone grafts to fuse the posterior elements. Understanding these distinctions helps us decide the best surgical approach based on the patient's specific pathology and stability needs. It all ties back to the overall goal of achieving solid fusion and optimal spinal stability. Let's break down some key terminology you'll often encounter in operative notes. First, when I say incision, I'm referring to the approach we take to access the surgical site. It's essentially how we get in. Next, disc work stands for excision, meaning the removal of the disc or disc material. Moving on, instrumentation refers to the device we use during the procedure, whether it's tools or implants. Then there's bone graft, which is what we sometimes call the column. This is the material placed to promote bone growth and stability. Finally, reviewing the operative note is crucial. It helps us understand exactly what was done and ensures clarity and accuracy in documenting the procedure. All these terms are interconnected, forming the language that helps us communicate the specifics of the surgery clearly and effectively. Let's start by clarifying that approach does not necessarily equal column. In other words, just because you're approaching a particular area doesn't mean you're working on the entire column. Typically, the cage is usually placed in the anterior column, so keep that in mind during your planning. When it comes to code decompression, make sure to handle it separately from other procedures to ensure accuracy and proper documentation. Always review the full operative report carefully, as it provides essential details that influence your coding decisions. Now, regarding fusion coding, there are some key decision tips to keep in mind. First, differentiate between the approach and the actual column involved. This helps prevent coding errors. Second, pay close attention to the specific procedures performed and document them thoroughly. These details are crucial for accurate coding and reimbursement. Remember, understanding these nuances supports overall documentation integrity and coding precision, which ties back to the broader theme of ensuring compliance and optimal billing. Fusion immobilizes the spine, providing stability and support for the patient. It's important to understand that the PCS qualifier helps us identify the specific column involved in the procedure, ensuring accurate coding and documentation. Remember, Any additional procedures performed during the surgery are coded separately, so we need to be thorough in capturing all interventions. Lastly, operative documentation is absolutely key. Detailed and precise notes are essential to justify the codes and support the surgical story. In summary, paying attention to these elements helps us ensure proper reporting and optimal patient care. Any queries? Thank you all for your attention today. Now, I'd like to open the floor for any questions or comments you might have. This is a great opportunity to clarify any points or dive a bit deeper into specific topics we covered. Remember, understanding these concepts thoroughly is key to applying them effectively. So, please don't hesitate to ask anything that's on your mind. I'm here to help ensure you leave with a clear grasp of the material. Once again, thank you for your participation and engagement throughout this presentation.